Welcome to this Webisode of Roche's virtual international experience exchange for patient organizations. With IEEPO 2020 having gone fully virtual, we have turned the content of what would have been discussed in Berlin this year into exciting virtual formats. Webisodes like this one have replaced the 6 original learning labs. They feature members of the IEEPO community and are available for viewing or download on IEEPO.com. They contain discussion questions and links to related resources such as e-posters submitted by patient organizations from around the world. This webisode explores the power of data to make better clinical decisions, and I'm happy to welcome Lorna Warwick as our speaker today. Lorna is the CEO of the Lymphoma Coalition, a worldwide network of 83 lymphoma patient groups. She has held senior leadership roles in health charities for more than 20 years and has a diverse background in patient advocacy, communication, and strategic planning. You can find her full bio on IEEPO.com. And my name is Bastian Haug. I'm a diabetes patient advocate, and I've been the IEEPO facilitator for the last 3 years now, and I have the great honor to interview Lorna today. So Lorna, our topic today is the power of data for better clinical decision-making in the context of personalized healthcare, of course. So let me start with a very basic question. Why is data so important? What kinds of data are there, and what is their role in supporting clinical decision-making?
Data is important because if you don't have data to back up your action or what you think, then really what you have is an opinion. So if we want to give credibility to the choices that we make and the information that we present to others, then we should have data to back up what we're saying. Now, usually when we work from a patient organization perspective, we usually work with 2 different types of data: quantitative data and qualitative data. Quantitative data, that looks basically at things you can measure. So you can look at how many people have a certain side effect, or what percentage of people participated in a particular program, for instance, things you can measure. Qualitative data, on the other hand, is more descriptive. It's things that people can explain to you about how they felt when they had a certain side effect. So it's not so much that they actually had it, that number, but what the fatigue, for instance, felt like, how that impacted their life. So when you're looking at quantitative data, you get very concrete numbers that are easy to show and to prove that something happened. So for instance, when we look at clinical trials, if so many patients had a certain side effect, you have a number that said X% of patients experienced this, and you need to be prepared if you take this medication moving forward that this may happen. Qualitative data is more about what that patient felt like when they had that side effect. It's a conversation that happens. It's an interview. It's listening to people speak and explain their experience. From that, it's still very important information to gather, but it's not necessarily as easy to explain at the end of the day how many patients, for instance, had a certain feeling. It's not the same kind of data in terms of we're not trying to put numbers on it. We're just trying to use it to understand better overall patient experiences and what actually happened to this patient as an individual as they went through their care. So where we see some differences is in how we might approach those different types of data, how we collect the data. Quantitative data is something you can easily collect through a survey, for instance. So if people go on a survey and they have check boxes where they say, yes, I had this, I didn't have that, it's very easy to count. You could still collect qualitative data through a survey because you can ask open-ended questions, but those are much harder to then go back and gather and analyze the data. Sometimes just because you're trying then to figure out what maybe the meaning was behind how people answered that kind of mechanism. But if you're sitting face to face with people when they're answering the questions, then you can ask another question and another question to kind of qualify or further describe what somebody is feeling or experiencing at any one time.
Lorna, qualitative versus quantitative data. Can we maybe dive in a little bit more? You already said the one is more something you can measure, it's numbers, and the others is more something like qualifiers that come out of a conversation. Could you maybe go quickly through the pros and cons of, what is great about qualitative and what is also great about quantitative data, and where are the main differences?
So we do have a slide to help you understand qualitative versus quantitative data. And we'll start with the qualitative and the pros. What you really need to understand with qualitative data is it's very rich data. You are talking to a person. And so when they give you a response, you can ask more questions to find out more about why they are feeling a certain way or what happened to trigger that kind of a response. So you can keep asking and asking until you fully understand a situation. And the other good things about qualitative data, of course, you're doing these one-on-one interviews or you're doing them in small focus groups. So it's a very personal connection that you're having with a patient when you're having these discussions. It's easily adaptable for cultural sensitivities. It's easily adaptable if you have people that speak different languages. There are some things that are much easier to do when you're sitting in front of a group of people than it is when you're having somebody fill out a paper survey, for instance. And at the same point in time, the information is really compelling, right? You have a personal story that oftentimes you learn so many things about what that patient's experience has been like, and you're emotionally, you react to that, right? Or you can look at somebody and be like, oh, that's such a fabulous success story, or it's amazing that you were able to get that kind of a response. So you have that relationship aspect to it, which is great. The cons: doing these kinds of interviews are expensive, right? You have to bring people together. I know you could do them on the phone, but really sometimes it's easier to do these kinds of things face to face when you can read body language, when we're allowed to do that, of course. It can be difficult if then you take all of these different interviews and try to make some kinds of assumptions of what an overall patient experience is like. It can be really difficult to interpret this data properly in a way that will be respected by other people when they review it later. Those can be the challenges with qualitative data.
Okay, so that's a great explanation of qualitative data and what it can be used for. So now let's look at quantitative and the pros and cons, just as you explained on the qualitative side.
So the pros for quantitative data really is it's easier in some ways to do, right? It's less time intensive. You're not sitting down and interviewing people. You're creating often a questionnaire. At least that's often what we do within the patient organization space, is we're creating a survey for people to answer. And so once you have the survey designed and available, whether that's online or if it's in printed versions, you distribute and then you just wait for the data to come in and then you do an analysis. So in that way, it can be less time intensive, definitely. It's easier to count. So we talked about with the qualitative data that when researchers are looking at all the information that they gathered through doing these different interviews, they have to decide, how do these fit together? How does all this information I learned fit together? In quantitative data, you know how it fits together because people answered the same question either with a yes, no, I did not, or they are rating something on a scale, like the intensity of this effect was a 5 for me, it was a 10 for somebody else. But there are things that are easy to measure and analyze that way at the end of the day. So if you want to, when you have all of the data in at the end of the day, if you want to break it down and see, is there a difference from one country to the next? Or is there a difference from one patient group to the next, whether that's male or female or age brackets? It's quite easy to do those kinds of analyses. The cons are you're only going to get information, of course, from people that fill out surveys or fill out your questionnaire. It's never going to be a complete picture of the patient group, ever. But that's okay, right? It will be really good, solid information, but you just have to make allowances for the fact that your data set will never be complete. It's sometimes when you're looking at the questions, you really have to think about the question that you're asking to make sure it's not leading. So you're not asking a question to get the answer that you want. You're asking a question to get the real answer of what it feels like from a patient perspective, and that the question is posed in such a way that it's easy for the patient or the person filling out the survey to understand what it is that they need to answer to this specific question. You often need a much larger sample size to make it sure that it is reliable, credible data.
Lorna, I really want to learn more from you about how to do this right. What, as a patient organization, you have to watch out for when you do this kind of work. Before we do, I'd like to break this down and make it a little bit more practical, because the reason you know so much about this is because you've been so active in this field. Your organization, the Lymphoma Coalition, you do a lot of data collection. You do a lot of research on the data that you collect. You recently completed a huge survey with I think 12,000 responses, which is massive. Can you maybe, before we go into the, what do we have to watch out for? What can we take away? What are tips and tricks in doing this? Speak specifically from your personal experience or from the experience of your organization, the Lymphoma Coalition, on what the survey was, how you designed it, what it was about, and what you used it for.
The Lymphoma Coalition started doing global patient surveys in 2008. So really the organization was ahead of its time. Before you heard buzzwords about, patient organizations being involved in collecting data, this organization made a choice to start doing that. And they did that because they really felt that there was a lack of information on the overall patient experience in lymphomas. And just to clarify, lymphoma is a type of blood cancer, but there are many subtypes of lymphoma. Really, now they estimate over 100. So it's a very complicated space to really understand the patient experience. And so I give credit to my predecessors because, of course, I was not with the organization when they started doing surveys. But the surveys have really developed over time. We definitely do quantitative data in terms of it is a survey. And it is like that because we gather data from as many countries in the world as we possibly can, with as many patients as we can. And for us to do that with qualitative data would be far too expensive. Now, the large scale survey that we do, I will not lie, is also expensive. So the number of respondents to the survey has increased every time we do it. And this time we did have almost 12,000 respondents, which is our best response to date. There's no question. And we are just starting to get those results and analyze them. We, as an organization, have very deliberately chosen to focus in this area of collecting, analyzing, and then also publishing our data. We do publish abstracts at scientific congresses. We contribute to other scientific projects using our data, working with other health professional research groups. We create papers out of our work pointing to things that are consistently identified as key issues affecting quality of life of patients. We use the data as well to itemize what's missing. So where there's a lack of equity in care and what patients are experiencing country to country. And we, of course, use that in our advocacy work. So there's lots that we do with the data. Because we are working in data all the time, I don't have a huge staff team working with me, but the team I have includes epidemiologists. So it's not just a case for us of making sure that we have the data and hiring a good company, which, by the way, we do hire an external group to help us conduct and do the initial analysis to make sure that there's no questions about the credibility or the way we ask our questions and the data is collected. But we also then do a lot of subsequent analyses. And so I have staff in place who have that expertise because it is such an important part of what we do.
So let me get back to that last point. I would translate it as professionalism, maybe scientific professionalism in knowing what you're doing. Probably, looking at our different audiences around the world here at IEEPO, not every patient organization will be in the position to have so many top scientific researchers in their organization. Like you said, you even have an epidemiologist. That's rather rare, I would say. But I think it is something to strive for, to really know what you're doing, as you said. And if you don't have the resources in-house, then maybe find them somewhere else. And that is important because otherwise the results of what you want to publish, the result of the data, the interpretation of that data will maybe not be credible. People will not believe that what you are taking as a conclusion is correct because they distrust your methodology, etc. And maybe rightfully so. So could you dwell a little bit more on that professionalist scientific methodology you need to have in there and how to go about it, maybe very concretely for a smaller patient organization that doesn't have the resources or the human resources in-house?
I have been working in the nonprofit space for a really long time. And I have worked at different levels. So I've worked at a very small organization as a volunteer. I've worked at a national level, and I am now working obviously at a global level. Any of those organizations that I've worked for have had the capacity to collect data and do some level of analysis. It's possible for everybody to learn how to conduct surveys, for instance, and conduct them in such a way that they can ask the right questions, probably to a much smaller group of patients, but have a targeted approach for whatever it is that they're trying to accomplish with the data. So for us as an organization, it was important that we were able to publish the data and be able to talk about it at scientific congresses. And to do that, we needed to match the type of data that was being published there by the researchers themselves. It's like, how do we make sure that there's nobody who's then going to question that we have a right to be here? And for us, that meant investing in hiring an external company to work with who was validated and could analyze the data in the same way that they would for other research organizations. For smaller organizations, though, you have other options. It depends on what you're trying to do with the data. But I've worked with a small, very small volunteer-run organization that became very effective in conducting small surveys on SurveyMonkey about their patient experience. It was a learned process for them. There was mentoring involved. They found somebody who had experience in this and was able to provide some guidance along the way. Sometimes they partner with a larger organization who has experience so that they can help them not only with analyzing the data, but making sure, again, that the questions are asked the right way. And we have some organizations as well that have partnered with health professional groups locally. And so they work together. Our patient groups often have better access to the patients than some of the clinical research groups. And so if we work together and make sure that the questions that are important to patients are also included in the surveys, then from the clinical research perspective, it's a win-win, and they will often do that and help it with the interpretation of the data and the way that it's collected.
So over to you now. You've heard what Lorna and I think. Now it's time for you to get involved and share your thoughts around our discussion questions in your group. So please discuss. How many of you have conducted surveys of your patients? How did you conduct these surveys? How was the data used? And who of you has good examples of evidence-based advocacy to share? There is one thing you told me that I found very interesting. It has to do with coalition building, with working together. As the Lymphoma Coalition, you run this big, massive survey. But one of the things you also told me is that you invited all the member associations who took part and thereby helped you reaching more people to respond. You invited them to introduce their own questions as well and ask their own specific, either locally. Can you dwell on that? Because I think that is a great way of leveraging the power of patient organizations, especially when they themselves may be not the biggest ones.
With the Global Patient Survey, this started in the 2018 survey. We did a test pilot actually with our member organization in China. They had some data that they wanted to collect. They didn't have the knowledge or necessarily the finances to be able to afford to do that. And we said that we would help. And so we let them ask a very small number of extra questions on the survey that only appeared to the people that were filling it out who lived in China. And we also helped them with the way the questions were worded to make sure that the information that they were gathering was credible and asked in a way that wasn't leading or expecting a response. And that was a really successful pilot program. The group in China from this was able to make some serious advances, not only in how they structured their programming locally to address gaps in care, but they also used that information to go to hospitals and say, we noticed this issue that's happening for patients. And they were able to open, I think it's 33 different kiosks at hospitals within China where they were manned by their volunteers who were able to help patients address some of their concerns while they were still at the hospital getting their care, rather than, going home and wondering, how do I get that information, and maybe not remembering completely what just happened. At the same point in time, they were also able to use the data to show regulators in China that there were some gaps in care that maybe would not reflect well on China as a country, that they were, allowing their citizens to have some suboptimal care. And therefore, there were some changes even within the government level about how they thought about lymphomas and how they would integrate some of this feedback moving forward. So this really was a perfect situation in terms of outcomes. So for the 2020 survey that we just did, we expanded that what was a pilot to any of the countries that in the 2018 survey had at least 100 respondents. And it is only to those that have at least 100 respondents, so we know there is some breadth to the data collection. So those countries were allowed to add up to 5 individual questions. And out of the groups that we offered it to, 10 of them did follow through. And because of that, we are now collecting some country level data that's important to the patient organization in these 10 countries. What was really good for them, and they've been, of course, very supportive of this initiative, is we do this at no cost to the individual organizations. We just absorb that cost into our survey overall cost and design. And at the same point in time, now we're helping them analyze the data. So now that the data is coming back, we're helping them understand what the data says, what the data doesn't say, and helping them create plans with what they could do with that data. And those plans are very individualized, right? So they asked different types of questions because they needed different types of information for different types of scenarios. So it's very much a customized plan per organization that participated. Some of them are intent on publishing data, so then we can look at it, we can do some comparisons against what we saw globally and say, this is where you veer, this is where you're right on line with what we see from a global perspective. This is an anomaly that we only see in your country. Let's see what we can do about this. And then for others, if they're looking at changing programming, what is this saying? If they're looking at using it for advocacy, what are we learning here about what's going on in their country and for their patients that needs to change?
I think this is super interesting. It's interesting in terms of what you were saying before, how to collect and how to include others in collecting. But that second part that you now touched upon, training your coalition partners on how to actually then work with what the answers show or maybe not show, and how to use that data is great. You mentioned the word advocacy. I want to touch upon that. Evidence-based advocacy is a term that is very important here. Can you talk a little bit about how you do this training, this working with your coalition partners on this evidence-based advocacy?
So data is never the end. Data is just the beginning. It's like you have this data, so now you have concrete evidence to support your story or to support your messaging and to lead you away where there is evidence showing that this is the best direction to go for patients, right? So whether that's showing, for instance, because we were obviously doing patient surveys to look at the patient experience, where there are gaps in care or where there's some kind of issue that is recurring every time we do the survey as an outstanding quality of life issue for patients. How do we start to close that so that patients have a better overall experience? Now, the same applies when you're looking at evidence-based advocacy. So part of what we do from a coalition perspective is we will then analyze the, almost 12,000 respondents we have and look at the different patient experiences within that data. We can look at them specifically and compare what their experience is like to somebody who is newly diagnosed, for instance, or going through their first treatment with the same exact disease to see how that changes over time. Oftentimes, when you are asked or when you're trying to help change regulations and get access to medications or diagnostics or whatever it might be, oftentimes the information provided to a regulator is for a very specific indication of patient. And so what we can do, like I said, from this data is match the experience to the indication that is coming through with the recommendation for a new treatment or test. From that, we can give an overview to our patient organizations who may be working in advocacy and say, this is what we know so far. So even if there is very little data in country, they can at least see then if what little information they have locally tracks along with the global larger scale data, right? So you can show sometimes credibility of your data by vetting it against a larger data set. You can see where things are matching and where there may be variances. What's really important, I find, is when you're doing evidence-based advocacy is matching your data or your presentation of information to the audience that you're addressing. A lot of times people who go into that field are coming from maybe a health economist background, or they come from some kind of health systems background, or even they may be physicians or other kinds of healthcare professionals themselves. And oftentimes they do think in numbers. And so if you can present the information in a way that reflects the person that you're approaching or speaking to, the way that they like to receive information, there's more chance that you will have a successful conversation. I know we are not all scientists. I know sometimes it can be hard to speak to somebody in what turns out to be a very different language, right? But it doesn't mean we can't learn to do it. And it doesn't mean that we as patient advocates need to understand everything, but you need to understand enough about what the different components that are being addressed and examined as part of a new drug approval, or like I said, new testing, new diagnostics, so that you converse at a level that the regulator respects and will also then treat you as a credible contributor to the conversation and and having something valuable to bring that other people have not been able to contribute to the conversation.
I would like to come back to that point because from my background as a patient advocate in the diabetes space, one of the research projects I lead, we had a lot of interaction with regulators. It was about, or it still is about, pushing a certain device to get approval. And the reasoning behind is very much an argument that comes from a quality of life perspective. So there is something that we want regulators to acknowledge, not because of hard numbers that it changes and outcomes in terms of mortality rates, because that's an endpoint I, as a diabetes advocate and as a person living with diabetes, I don't even want to think about. I don't want to think about my mortality and whether it's going to be in 25 or 28 years or whenever. But quality of life is what really matters to me, like right now. And then we did a survey, a qualitative survey with open-ended questions, asking people about their quality of life. And we got a good team together that knew about the research methodologies and the science behind how to turn open-ended questions and answers thereto in a qualitative way into a set of numbers, basically. And it changed everything. And it also allowed us to have that conversation. It allowed us to say, listen, these are the questions we asked. These are the answers we got. But if we run the numbers there behind that, because answers to open-ended questions is still data, as we said in the beginning, if you
Yes.
treat it right. And with that, suddenly all the doors were open, and suddenly they would listen to even individual cases and single individual stories and why this matters to one person, because we could back it up. And that was such an eye-opener for us to change that whole conversation around.
Yes. I think when you look at all of those scenarios, you're completely right. What you can also do, though, when you're looking at quality of life is, I know from us and the research that we've done, is there's an assumption when you're diagnosed with a cancer that patients just want to be cured. And there is some validity to that if you're a patient in the early years of your experience. So if you're newly diagnosed and you've been told you have cancer, oftentimes, of course, you want a cure. And cure can come at any cost because the patient doesn't know yet what that cost is. When you examine the data for patients that have been in this for the long haul, quality of life becomes more and more important to them, oftentimes more than cure. Sure, they would still like to be cured, but at any cost is no longer on the table. So for us, it is being able, at least with the survey now, we ask questions about what's most important to you in a new therapy. And then we can break it down by the different stages of a patient experience and again, bring it to regulators or politicians or whoever it might be and say, you need to rethink your own perspective of this, because I think from just a global community, oftentimes when we think of a disease like cancer, you think, no, we need to cure. And sometimes what is most important for a patient is really how do you control my cancer in a way that I can still do all these things I love to do and maintain a really good quality of life. And reframing those discussions when you have data behind you is so much easier to do than it is trying to convince someone that a societal norm that they adopted a long time ago is really not true for the entire patient population.
We talked a lot about data, qualitative, quantitative, how to get it, how to do a good survey, for example. Coming back now to the topic for today, can you comment on how data can be used to improve clinical decision-making?
From a Lymphoma Coalition perspective, over the last few years, we've had a very deliberate effort within our survey to ask our own research questions. And one of the questions or the ideas we've been exploring is really around the fact that we all the time say that a patient needs to be more informed. But there wasn't a lot of science or information behind that on why we think that's important, right? It was so, it sounds like a great idea, but does it actually make things better for the patient at the end of the day? And so we asked questions about how informed patients felt. So people that were adequately informed or somewhat informed or inadequately informed. And what we were able to prove very clearly is the patients that said that they were adequately informed and had the best level of information also reported that they could better manage their own healthcare. They knew what to do with their side effects. They were more likely to know what their medications did and how to use them. They knew the standards and processes of their care, what their care trajectory was look like. They were having better conversations with their doctor. They reported just a very much more improved overall healthcare experience. Now, that doesn't mean because they're well informed that we can predict how their cancer progresses. What we're saying is the patient responds to everything that comes their way in a much better way overall. So we have definitive proof that it is better for a patient to be as informed as possible. The latest survey that we did also looked at then how that ties into decision making. So are informed patients really more active in their decision making? And it's not a surprise that yes, they are. So I think from a patient organization perspective, having really good, credible resources available for patients, making sure they're updated, finding ways to get that information into their hands really is important in ensuring that there are better outcomes for our patients overall. I think from our angle, what's important here is making sure that we're equipping our patients with as much information as we possibly can so that they can have those better conversations, they can better manage their health, and they can overall have a much better patient experience.
So Lorna, to close off this session on how to do a good survey and how to collect the right data to do what you want to do as a patient organization, can you walk us through again what the key questions that you need to ask yourself before going about it, and then also how to do it right, how to design, for example, a survey right to get the data that you want?
So when you're looking at your different types of data that you might want to collect, really you have to figure out first, what are you trying to do with the data? Who is your audience? Or what is your plan for the data that you have? And that can affect what kind of data you select that you're going to try and capture. You also then have to be very clear about your audience. So who eventually are you going to be presenting the data to? Because that can also influence what kind of data you collect. If you are going to approach regulators or politicians or doctors, researchers who think in numbers often themselves, then it's probably better that you have quantitative data that is easily measurable, or at least qualitative data that has been measured or quantified so that you are giving them numbers, because that's what they respond to. If you do not have a clear idea of what you're going to do with the data, it can get very broad very quickly, and you will not have any really good concrete information to use at the end of the day. You're going to have to figure out how to ask the questions in the right way so that you're getting people's honest opinion and you're not just getting the response to the question that you hoped. So think very much about how to make sure that you're incorporating even if they are bullets or multiple choice, that you're giving people lots of options in the way that they can respond to the question. Again, when you're thinking about the questionnaire, you have to figure out how are we going to administer it? Is this going to be an online questionnaire? What kind of mechanism are you going to use? Is SurveyMonkey sufficient? Or do you need to invest in some more advanced software? When you have the questionnaire ready, have somebody test it. So invite people that you know who fit into your target demographic. Have them complete the survey. Was it easy to do? Did you understand what the questions meant? Was there something missing that we should have asked? Have people test it and give you their honest feedback. And by the way, do test it yourself. If you use something like SurveyMonkey, for instance, for a smaller scale survey, that has the ability to do some analyses for you in the back end, which is helpful if you're new to this. Again, though, if you have some healthcare professionals that you work with locally, or a local university, or college or something that has a diploma program in statistics. Oftentimes they're looking for projects for students to do from an internship perspective, or so that they get some real life experience. Maybe they'll be willing to help. Don't be scared to ask other nonprofit organizations locally that you know who do surveys if they have any best tips, or if there's a way you could share and collaborate on initiatives. Think about those people you know internationally working in the same space or a similar space who might be interested as well, especially if you're new to this, and making sure that you have some good information and support as you try your first time to collect some good data. But don't be scared to try. Try. You never learn anything unless you attempt it.
On behalf of the Roche Global Patient Partnership Team and the IEEPO External Advisory Committee, thank you very much for being with us today. And I'd also like to thank Lorna for joining me today and sharing her thoughts around harnessing the power of data and how that can help make better clinical decisions. You can now visit IEEPO.com for more information about her and more information on this topic, including downloadable e-posters. And if this discussion has inspired you to learn more, you will also find more webisodes on the power of data and the digitalization of healthcare on IEEPO.com. We will be adding regular updates, so stay tuned and check back regularly for more around this and other topics. Thank you very much.